The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Good day to you all. I'm Tony Urbanek, and we are here for another edition of TMD Demystified. I hope all of you TMD warriors are with me and have enjoyed at least some of the prior podcasts that I put together regarding this issue of TMD. Today's edition will focus on what are the common causes of inflammation within the temporomandibular joint. If you recall briefly, inflammation within the temporomandibular joint is the total common denominator of all the symptoms. You have the symptoms of temporomandibular joint disorder, and you have what causes the symptoms. And the cause of the symptoms is not what is usually referred to as the causes. The cause of the symptoms is inflammation in the joint consistently, and all the symptoms. Inflammation causes headache, earache, jaw pain, neck pain, ringing, fullness, dizziness, shoulder pain, arm, hand, finger tingling, and numbness and locking. But inflammation is the common denominator, but what causes the inflammation? Well, after now treating well over 3,000 patients successfully, non-surgically, by unloading the temporomandibular joint appropriately and consistently with an appropriate device that can be used, I have proved to myself there are only three causes, and these are well known. I'm not telling you anything that's not in the literature, that's not discussed, but there aren't four causes, and there's not two causes. There's three causes that actually cause the inflammation. So we'll just reel them off briefly. Number one is bruxism. Number two is acute trauma. And number three is functional malocclusion. 1, 2, and 3. Those categories have subcategories. And we'll go through this hopefully in a way that will make sense to you. But it's all about how you look at this problem. And I think that one of the reasons that TMD has gotten such a bad rap about being confusing and don't know anything about it. I've talked to so many dentists that, I don't want anything to do with TMD. It's totally, I can't understand it. It's like, no, this is really an easy to understand problem when you actually look at how it originates, where it comes from, know a little bit about inflammation and a little bit about anatomy, physiology, and the autonomic nervous system. Explains it really well, but that's for another time. Today, we're going to talk about the primary causes of inflammation within the temporomandibular joint: bruxism, acute trauma, and functional malocclusion. We'll leave that to the last because that, I think, is the bigger discussion. So bruxism, grinding the teeth, clenching the teeth. Either one will cause inflammation. They're not the same. Bruxism is moving back and forth, and clenching is just clenching tightly. I see as many people who clench as many people who brux. As far as the effect on damage to the joint, it's all about the same. How common bruxism is I think not really worked out. In my mind, I would say, after talking with thousands and thousands of patients, doing thousands and thousands of consultations, probably half the population in the United States of America bruxes or clenches to some extent. Most are not aware of it. Some are acutely aware of it. Some have been diagnosed by other doctors one way or another. But the gold standard on diagnosing bruxism at night is the bed partner, sleeping partner, is bringing the attention, my God, you make a lot of noise with your teeth. That is the gold standard. Of course, there are other ways to determine whether there's bruxism, wear on the teeth, periodontal problems. The big one that I find not many dentists know, very few dentists know about, is the creation of lingual and palatal tori and buccal exostoses. Buccal exostoses, palatal tori, lingual tori. Those bony lesions, extra growth, are only formed by people who clench or grind or who brux. Brux is the generic word, clenching or grinding. Most dentists know what to call them: exostoses, lingual tori, palatal tori, and if you ask the average dentist what causes those tori, they'll kind of don't know. But when you understand bony physiology well, as I studied in detail in my career, it's very clear how those tori form. Again, that is a topic for another totally different edition of this podcast. So, number one, when you see lingual tori, palatal tori, buccal exostoses, you can be assured that that patient bruxes, and you can be assured that sooner or later they will begin to have some kind of breakdown within the temporomandibular joint, because just like jogger's knee or tennis elbow, the more you use it, the more you abuse it, the longer it goes on, the more damage goes on. So that's one thing to look for in your practice in your dental office, both from you and your hygienist and other people that examine the patient. Very, very common. I would say half the population bruxes, and when you see tori, you can be assured that they do. And then you can start, then you wonder, well, maybe this patient has the symptoms. Well, if they have inflammation, it will hurt when you do that self-examination that we've talked about several times. And then you can offer treatment. What we do around here, we just tell a patient what we see, what we know, and ask them if they'd like those symptoms to go away. And of course, most of them do. All right, so that's pretty much what I have to say about bruxism. There's, of course, it's a lot more. Oh, one other thing. Patients have no ability to stop bruxing. Don't let anybody tell you they know how to get somebody to stop bruxing their teeth, or grinding their teeth. It doesn't exist. Patients cannot control it. And the only thing we know for sure about bruxism, it is related to stress. The more stress, the more people tend to clench or grind. And we do not even have a good definition for stress. Patients will tell me all the time, oh, no, I know what stress is. Stress is my husband. Stress is my job. No, those are stressors. But when it comes down to actually the definition of what is stress, what goes on when you have a bad day, when you have a bad marriage, when you have a bad job, what goes on inside, we don't know. We have ideas or theories, but we don't know. So don't let anybody tell you that we know how to get people to stop bruxing their teeth. That obviously is not what our device and protocol does. It doesn't stop anybody from clenching or grinding. All right, enough about bruxism. Second one is acute trauma. Obviously, they can come in many forms. Injuries in sports, very common, motor vehicle accidents, and the actual symptoms after an acute trauma may not show up immediately. That's one of the things I've seen very, very often. It can show up immediately. You can have almost immediate pain of different varieties originated from the temporomandibular joint with acute trauma. And of course, I'm well experienced with acute trauma, treated, I don't know how many thousand maxillary, mandibular, facial fractures in my career, in my early career. But acute trauma will damage can and will damage the meniscus, set off inflammation, and then on many occasions, the damage within the joint does not create enough and significant long-term inflammation, and the symptoms will show up much later on. But you sometimes can relate it to a specific accident, but not all the time. It's very difficult to relate TMD to a specific piece of trauma unless the patient can say, I had an automobile accident and the following day or the following week, I started having major headaches, or I started having significant pain in my neck or my jaw. So, but acute trauma is one of the three causes of inflammation in the joint. And one factor about this acute trauma, and is very frequently seen with whiplash injuries. And the issue with whiplash is that when the whiplash occurs, very rapid in the deceleration, very rapid snapping the neck back. And of course, you can damage the neck, no doubt about it, but also the mandible will snap open widely, in some cases, much more widely than it is built to open. And it'll stretch the ligaments, and it will stretch the tendons of the muscles, and it will dislocate the meniscus, and actually can dislocate the condyle head way in front of the glenoid fossa. Whiplash is commonly seen as an instigator of temporomandibular joint problems after accidents, especially motor vehicle accidents. So one of the particular questions I ask when I do a consult is, do you have any history of trauma to your face, especially any history of whiplash injuries of any kind? And then the third category, which take a little more time to discuss, definitely in depth, is functional malocclusion. And what is a functional malocclusion? Well, in my career as a maxillofacial surgeon, I thought that a functional malocclusion was a big old class 3 with the mandible sitting out half an inch or more out in front of the maxilla, or a big old class 2 where the mandible was this, or the maxilla was way out here in front. A big old class 2 that was a functional malocclusion for sure. And what we know are functional malocclusions because of the difficulty in mastication and the difficulty in occlusion. Will put extra loads, one way or another, extra loads, because it's all about loading is the cause. And of course, unloading is the solution. But the extra loading, which is consistent with bruxism, with acute trauma and functional malocclusion. Well, I disabused myself of the fact a long time ago that functional malocclusions are only big class 2s and class 3s. Functional malocclusion, as it turns out, can be even small differences between centric relation and centric occlusion. I have seen many patients who struggle with a CO-CR discrepancy of, a couple millimeters and mandibular slides that over a period of time, with their attempt to chew with this CO-CR discrepancy, will overload the joint, create the inflammation, which creates the symptoms. So that brings up the fact of, well, when you treat and you unload the joint and you make the symptoms go away, what do you do about the functional malocclusion? Well, that is where our orthodontic colleagues come in, and sometimes reconstructive efforts dentally will be helpful. It depends on what it takes to get the CO-CR discrepancy corrected so that they have a function of the mandible against the maxilla that does not overload the temporomandibular joint. Which brings up a point about my orthodontic colleagues, and not being orthodontist, I'm not going to put myself out on a limb, but I can tell you that I stress and I emphasize the mechanisms that some of my orthodontic colleagues use to correct bite problems, especially in children, by pulling their mandible forward with different kinds of devices, internal devices, external devices, can have a significant detrimental effect on the temporomandibular joint, the health of the temporomandibular joint, and damage to the temporomandibular joint, because I have seen many, many, many cases of that. So I just warn you, make the statement that it does happen. And I'm well prepared to defend my position on that, and I encourage questions and comments about that. But there are, even in the Middle Tennessee area here, continued procedures done by orthodontics that don't consider, when they're pulling on the mandible, what it's doing to the temporomandibular joint. And whether it be 2 years later or 30 years later, when I see that patient and I get a history from them, I can pretty much determine that where it started from, and that is excess loads on the joint by traction on the mandible orthodontically. So functional malocclusion does not have to be a big difference. It can be a small CO/CR discrepancy, and that is where a lot of you come in to play, whether you be general dentist or orthodontist or oral maxillofacial surgeon, to correct that CO/CR discrepancy that unloads the joint over the long period of time. Now, what I've seen in my practice here over the past 7 years, which has been very, very busy over the past 7 years regarding non-surgical TMD services, is that when you unload the temporomandibular joint long enough, the symptoms go down, and then you must address, for the patient's benefit, the CO/CR discrepancy, and I send them out to one of my orthodontic colleagues, or if it's a very slight problem, I'll send them out to one of my general dental colleagues to try to correct that CO/CR discrepancy in the least complicated, the least expensive, the best way for the patient. Then and this is the kind of practical nature of it, and this is what I've seen, about half, once you unload the joint with a kind of a normal CO/CR position, about half of the patients, that's all you ever have to do, and about 50% of those patients have to go back in to this device on a nightly basis to keep the joints unloaded, which will decrease keep the inflammation down to the point where the symptoms don't return. So even after you fix the CO/CR, 50% of the patients still need to go back into a device, maybe because they're bruxing, or maybe because there's so much damage within the joint already that they have enough inflammation within the joint that it creates the symptoms. If you follow me along up to this point on all these podcasts, I'm sure that you get the point that we're talking about inflammation, the way it is created, the way it is made to diminish. That is what you really need to know about TMD. It's like, what makes inflammation in the joint excessive, and what makes inflammation in the temporomandibular joints diminish. If you understand that, then you can understand the solution. And when you understand the solution, you can put it into practice in your practice. I like that. So that's what I have to say today. Again, this is one of the more brief podcasts, and I think that's good. We don't have to have long, drawn-out dissertations. As always, I appreciate you watching. I appreciate your comments and questions. I really hope to hear from some of you who would like to do this in your own practice, for the benefit of your practice, and for the benefit of the patients, and for the benefit of the professions. So I look forward to hearing from you, and I look forward to the next time that I'm able to talk with you.